Yeah, I can do that. Hello. Hello, good morning or afternoon, everyone outside. This is our great webinar for question and answers. Answering all the questions that you will send. As an introduction and a petition for the people who have sent their questions, if you would like to interact with Gordon, I will please ask you for your Google emails so I could add you to this meeting or webinar, so you can be in the inner circle and interact with Gordon Guyatt. These webinars have a limit of 18 to 20 people to be inside this webinar and interact with Gordon and with us. So if you would like to interact and explain a little bit more about your questions, that will be awesome. So if there are no chances, or you will not like to interact with in this occasion, that's fine. But it will be more interesting to have these several questions and this interaction with us. So without further, I don't think Gordon needs further introductions, but we have an audience. We have Gordon Guyatt here, and we would like to start with the questions that you kindly sent us.
So just one, we believe in interactive teaching where people think about the issues rather than just the question and I immediately present the answer. So to help that, we have three people in the room, Carlos being one, that you will see me, you won't see them, but I'm going to ask them for at least some of the questions to provide their thoughts. And what I hope that will allow you to do is think about it yourselves before I offer my ideas. And the people in the room may ask questions, please do, to if there's something that's not quite clear, then we can have questions from within the room, and that will help people. And once again, as Carlos just said, it would be great if people sent Carlos the Google address, the
email address,
Google email address, and then we can get you in, so that if you have people, you can type in questions anyway, but much nicer if you can speak your question, and if you come into the inner circle, you'll be able to do that. And the people who we most encourage to do that are the people who have questions that we're going to be addressing.
That's correct. And also in the Facebook page or website of the Great Working Group, you can find instructions and even type in there your email address, so I can introduce you into this circle of the meeting, so you can ask questions directly and by voice. So that will be awesome. Okay, so we can start with the questions already, and I'm going to share with you my screen so you can have a visualization of the first question.
Okay. So the first question is how to balance desirable and undesirable effects in clinical practice guidelines. So, people in the room, thoughts about how you balance desirable and undesirable effects in clinical practice guidelines.
Yes, I think one part of this is, let's say, if you have a drug with a really nice benefit, and to reach this evidence, you have confidence, so you try to minimize, or you didn't identify huge bias, but at the same time you identify some side effects. So my question is how comfortable you are to decide the thresholds between one thing and the other thing. So that is the point.
Okay, so you've identified very nicely the issue that there may be thresholds involved. Okay, so let's go through an exercise about defining thresholds. Okay, which may be helpful. So let us take, we have individuals with atrial fibrillation. And individuals with atrial fibrillation have a risk of stroke. But we can give anticoagulants to decrease the risk of stroke. Unfortunately, the anticoagulants also increase bleeding. So we're talking about stroke. You may end up with quite a disability. One side of your body is weak. You have difficulty speaking and understanding. So stroke is quite bad news. You wake, feel terrible, you vomit blood, you are terrified, have to go to the hospital, a tube has to be put down, and eventually, in a week or two, you get out of hospital and gradually recover. Okay? So let us say you are in a situation where in 1,000 patients, you are going to prevent one and bleed. So you take the anticoagulant, your bleeding risk goes up by 30%, 3%, your stroke risk goes down by 0.1%. 1 in 1,000 prevented strokes causing 30 bleeds. Anybody here interested in taking anticoagulants under this circumstance? No, nobody's interested. Okay, so now we're still causing 30 bleeds, but we are preventing 100 strokes. So a 3% increase in bleeds, a 10% reduction in strokes. Okay? Under these circumstances, are you interested in the anticoagulant? Yes.
Much bigger.
Yes. But no, I'm asking a question now. Much better, but are you interested, yes or no? The answer is?
Yes.
Yes. Okay. So we all said no, and we all said yes. That means that somewhere between one stroke, when there's 30 bleeds, somewhere between one stroke prevented and 100 strokes prevented, there must be a threshold, right?
Yeah.
So I'll ask the people in the room. Don't think too long. It's not an easy question. But where is your threshold? Given your bleeding risk will go up by 3%, what decreases in strokes would you require to use anticoagulants?
Difficult. I would say 5.
Okay, so Carlos says 5. Sergio? Come on.
Maybe 10.
Okay. So how do you spell your name?
Houston. Housn.
Housne.
NE.
Okay. Says 10, and Sergio 15. Okay, so we have a range between 5 and 15. So we now see the terminology we use, values and preferences differ. Okay? Somebody says yes. Somebody says yes with very few strokes prevented. Some says with more. But a guideline panel cannot give a guideline for this people and a guideline for this person. A guideline panel has to use typical or average values and preferences. Okay? So one way of thinking about this, we have 30 bleeds. Carlos is ready to say 5 strokes prevented for 30 bleeds. He's saying a stroke is 6 times as bad as a bleed. 30 bleeds, ready with 5 strokes, that's equal. A stroke is 6 times as bad as a bleed. Housne said 10 strokes equals 30 bleeds. A stroke is 3 times as bad as a bleed. And Sergio said 15 to 30, a stroke is 2 times as bad as a bleed. So everybody agreed a stroke is worse. Okay. Now, as it turns out, we actually have some evidence about this from more than the 3 people in this room. Okay? And so there's been probably about a dozen studies that in one way or another has asked patients this question about the trade-off between stroke and bleed. And it turns out the typical, we see this same kind of variability, but the typical or average answer is Houseby's answer, okay? So the typical, and just by coincidence, you were in the middle too, and it expanded, so that's consistent with the much broader evidence. So we came up with 1 stroke equals 3 bleeds. And in a clinical practice guideline that we did, where we asked this question about should we be recommending anticoagulants for people? And it also, we dealt with deep venous thrombosis. We said 1 stroke equals 3 bleeds, equals 3 myocardial infarctions, equals 3 deep venous thrombosis, equals 3 pulmonary embolism. So we made explicit the trade-off, okay? So bleed equals an MI, equals a DVT, equals a pulmonary embolus, deep venous thrombosis, and each of those are worth, their disutility or aversiveness is 1/3 of that for the stroke. So if, Carlos, you can quickly put up the atrial fibrillation example from that article, and we can look at that together, and I can illustrate how one applies this. I'll do this only if it works quickly. Not that one. Okay.
Oh, I have it.
Another 10 seconds you've got, and we're going to move on. Not that one. The company will use that one, but. Okay.
Not
So,
atrial fibrillation.
yes, it's the atrial fibrillation table 3. Or table 2, yes. Okay, so.
Table 2.
Okay, and you're going to need to, that's table 1. I think I did this one by table 1. No. That's it.
Okay.
Okay. Now, I hope people can see that. Why don't you come around and have a look as well? So let's go to the right side. And what you can see is that we can stratify people with atrial fibrillation by their risk of stroke. So can I use a point here?
Yeah.
So here's the lowest risk is 8 per 1,000 per year. Anticoagulants are pretty good. They reduce it from 8 per 1,000 to 3 per 1,000, which is 5 fewer strokes. Even the next one is 15 fewer strokes. Now, if we go down, maybe you can help me, Carlos, just go down a bit there. That's fine. We don't need to go any further. We have 8 more bleeds, okay? So for the lowest category, we have 5 fewer strokes, 8 more bleeds. So if you said a stroke was equal to a bleed, you would recommend against anticoagulants. But we say our best guess as values and preferences were a stroke is 3 times worse than a bleed. So that 5 decreased strokes gets a weight of 15. So now we have 15 good, 8 bad, and we recommend in favor of anticoagulation. But it is close enough, a close enough call that the recommendation is only a weak recommendation, because with Sergio's values and preferences, he said a stroke is only twice as bad as a bleed, and then the weight of the 5 fewer strokes, well, that still goes up to 10 and 8 bleeds. So still, but only slightly in favor. And if somebody were even less stroke averse, then they would make the other decision. So when it's a close call, then we make a weak recommendation. If we go back to the table and look at Chad's 1, we now have 15 fewer strokes, 8 more bleeds. So you're clearly going to recommend for anticoagulation, but now the strokes are worth 45 points, if you will, against the 8. And now we think probably everybody would choose the anticoagulants, okay? So the way you have to balance is you have to look at the relative aversiveness or disutility of the treatment and think about the range of values and preferences in your population. So let me just take you through one more example to illustrate the point, and you can use the one that you kept putting up here a minute ago, which was the one from the user's guide book.
Okay.
That's it, okay? So come around again. This one is about, you are going for, you have a bad hip and you need to get your hip fixed. Sergio and I are in the age category, and actually I've already had my hip fixed. Okay, so I was in this situation. And you've had coronary artery disease, or you're at high, or you have diabetes and high blood pressure and you smoke, so you're at high risk. And the question is, should you receive a beta blocker drug to slow your heart before you go to surgery to prevent bad things from happening? Okay? Now there's been randomized trials, and here's what they show. What they show is 14 fewer heart attacks if you that's about a 1.4% reduction. But it may be as little as 6 per thousand or as much as 20 per thousand. And we have pretty high confidence in that. Unfortunately, our best guess is 2 more strokes, but it may not be any more, or it may be as many as 6 more. And unfortunately, it's 6 more deaths, but it may not be any more, or it may be as much as 13. So best guess, 14 fewer heart attacks, 2 more strokes, 6 more deaths, but we're confident that there's going to be at least 6 fewer myocardial infarctions, and there may not be any more deaths or strokes. Okay, Carlos, you take the beta blocker or you don't take it with that picture?
Yeah, why not?
You say yes. Carlos takes it. Sergio?
No.
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 Houseney, no. Okay, so here again, we have values and preferences that differ. So I don't know exactly what Carlos was thinking, but he was saying, I'm pretty sure I'm going to get some benefit in myocardial infarctions. There may not be any harm here. I'll go for it. Whereas Houseney and Sergio were putting clearly a greater value on the risk of death and stroke. Okay, so what does this tell us? This tells us, we have our 3 people, what the panel has to do is make their best guess as to the values and preferences of the population, okay? And if there's some data, then you can use that. If not, you have to, clinicians on the panel, and maybe you have patients in the panel, but anyway, people have to say, what do we think are the values and preferences, okay? And this one, if we just use the 3 people in the room, what would we say? We would say our recommendation would be against beta blockers, but it's going to be a weak recommendation because it's a close enough call that the variability in values and preferences, maybe go back to looking at me.
Yep.
the variability in values and preferences is such that some people, even though most people will say, no, thank you, there may be some people who say yes. So to review the principle then, the principle is in making the choice between when there's good things and bad things, you have to decide how good the good things are and how bad the bad things are to make the trade-off. And guideline panels cannot, we know there's going to be variability, they have to use average or typical values and preferences when we do that. And ideally, people will be explicit about their value and preference judgments, and ideally, they will be quantitative the way we were in the antithrombotic guidelines, where we said our best guess is patients would be equally keen to avoid a heart attack or a deep venous thrombosis or a gastrointestinal bleed or a pulmonary embolus, but they're much more averse to strokes, which are worth 3 times as much. Line then is you need to decide what you think your typical patients are going to value, the relative value they put on the benefits and the relative value they put in the harms, and then make your judgment accordingly. In terms of that question, any questions in the room about that explanation?
Will it be like kind of like relative thing then? Or the decision at the end of the day? Is it like a relative that how confident we are that, okay?
Well, so there's 2 reasons. Okay, so if we are very confident of our recommendation, we make a strong recommendation. And if we are not so confident, we make so in the situation we've talked about, when we were preventing 15 strokes and causing 5 bleeds, we had decided typical patients value this 3 times as much as this. So this is 45, this is 5. Well, we think everybody or virtually but when it was only 5 strokes prevented and 8 bleeds caused, if it were a little more bleeds, then it'd be even more, we think, well, most people, this is 15, this is 8, most people will choose the anticoagulant, but some will not. And then we're not so confident and we make a weak recommendation. Does that clarify?
Yeah, it is.
Okay. Any more questions here? Are there people online who could ask questions?
Not yet.
Not yet. Okay. Okay. Let's go to the. So here, I would encourage you if you were joining us in the inner circle, which I hope for the next webinar we'll have people. Then you could ask a question too, and I guess we can take type questions, but much nicer to be able to talk. Okay. What does GRADE do with good practice recommendations? Please give examples of the format and language of presenting good practice recommendations and how the format from graded recommendations. Okay, so the person who asked if you could go to our article that we published in the Journal of Clinical Epidemiology about this, please. So the person who asked this obviously understands good practice recommendations, but everybody may not understand it. So I'd like to begin by explaining good practice recommendations. And I think the best way to explain this is to go to the article. Yes, yes, yes. So let's go to the article, please. So come around. Okay. go down the article, please. And there, go up now. Look at box 1, okay? For patients with congenital adrenal hyperplasia, we recommend monitoring patients for signs of glucocorticoid excess. So patients with this condition are at risk of getting glucocorticoid excess. Now, one way to recognize this good practice statement is that the opposite recommendation would be silly or common. So can you imagine in patients with this congenital hyperplasia at risk of glucocorticoid excess, we recommend you not monitor. Okay, that would be pretty silly. Okay, next one, triage, take different courses of action for low versus higher pretest probability people with tuberculosis symptoms. Okay. The opposite recommendation was anyone with cough and fever, put them in isolation as if they have tuberculosis. That would not be a very sensible thing to do, or you isolate people. Okay? Third one, health services should be made available, accessible, and acceptable to sex workers based on the principles and so on. Think of the opposite. We recommend that good health services not be made available to sex workers. Rather silly, okay? So these good practice recommendations can be recognized. They are things that are obvious, okay? And you can go back to, go back so people can look at me. Why would people do this? Well, for some reason, the guidelines, even though you and I would think the opposite is silly, they feel compelled to tell their audience. Rightly or wrongly, they feel compelled to tell their audience. And you could go through these things with a full grading exercise. So let's start with the congenital adrenal hyperplasia. Okay? So the good practice, what should be a good practice statement, was monitor for glucocorticoid excess. Okay. So what you could get pieces of evidence. Can you monitor? Okay. So for instance, is it possible to easily monitor? Can you recognize? What is the evidence that we can recognize glucocorticoid excess? As it turns out, it's pretty good. We're pretty good at that. And number two, if you find glucocorticoid excess, can you treat? Okay, answer is yes. And three, how successful is the treatment? Answer is pretty successful. So a panel could make a graded recommendation, but first they'd have to look at this, then they'd have to look at this, then they'd have to look at this, because no one's been silly enough to do a randomized trial of monitoring versus not monitoring. So they'd have to put up all this indirect evidence and then put it together, okay? Guideline panels do not have infinite resources, and they do not have infinite time. Therefore, this would be a bad use of their time. So, if they feel compelled to do this, we suggest they not go through and look at these three bodies of literature and try to put it together. They just make a good practice statement. Okay. So, but these are ungraded, so you need to differentiate. So a guideline panel in their recommendation needs to differentiate these good practice statements from real graded recommendations. So the format we grade suggest to people, one we like the best, is for a strong recommendation, we recommend at and then we would say strong recommendation based on, for instance, high certainty. And for a weak recommendation, which is sometimes people also like to call it conditional, we say we suggest X rather than Y. Weak, and maybe it's on low certainty evidence. That would be one reason to go from strong to weak, is the close balance between desirable and undesirable that we talked about earlier. Another is if you have low confidence. Okay. What the panel needs to do if they're going to make good practice statements is separate your graded recommendation and have a big heading that says non-graded good practice statements. And there's various ways these then could be worded, but they should be worded very differently. So and there could be different things. The panel believes that good practice involves doing X rather than Y. So that might be, or another would be standard practice involves, or say dictates, X rather than Y. So panels can the graded recommendation from these good practice statements. So you put them in a different part of your recommendations, something different, and you choose wording that is quite different from the wording of your graded recommendations. Okay? Any questions here? Okay, and you still don't have anybody online who can ask questions? No. All right. Okay, so let's move to our third question. And our third question is, we are used to produce recommendations of new oncologic drugs, usually with few studies available. In some, we have to evaluate a drug approved by EMA. Anybody, do we know what EMA is? European Medical Agency, with only one phase 2 study without a control group. We can include this kind of studies in the group of non-randomized studies. Which approach to rating quality of evidence? Okay, now the first thing is, what this highlights is ambiguity about what is quality of evidence. Okay? What do people in this room, so when I say quality of evidence, what do you think of? What do you think? What Carlos, what's quality of evidence?
Well, I already great people. It means the confidence. How confident you are.
Confidence in the estimate.
Yes.
But quality of evidence has been used to mean something else. Can anybody think about what quality of evidence has been used to mean historically?
Usually the goes to the design of the study where you're
Yeah.
saying, yeah.
Right, okay. Risk of bias. And this came to mind because, let's go back to the question. The second part of the question is, can we consider which criteria should we use to downgrade if necessary? For example, if we have a subjective outcome, should we use the risk of bias assessment for cohort? Okay, so just to be clear, quality of evidence has been associated with risk of bias historically, but we also mean precision. When GRADE has been using it, we mean precision, and we mean consistency, and we mean directness, and we mean publication. So, because we recognize that when we said quality of evidence, when we mean all these things, but people were thinking we mean risk of bias, we often now use confidence in the estimates as opposed to quality of the evidence, or certainty in the estimates as opposed to quality of evidence. But they're synonyms, okay? So we go back to the question. So the answer is, here's a phase 2 study, and you say there's without a control group. It's without an internal control group, but I'm sure if the agency is licensing it, they must have at least an implicit historical control group. Okay, so if I say they give the new drug to people in the phase 2 study without a control group, 90%, I don't. Okay, so even if they haven't got an internal control, they do have an external control. And can you consider it like an observational study starting from low quality? The answer is yes. And what should be used to downgrade if necessary? For example, if we have a subjective outcome, should we use the risk of bias for cohort type studies as reported in ACROBAT non-randomized studies? Answer is yes. For risk of bias, you could use this non-randomized studies. But right away, you might rate down to very low because there's no internal control group. So that would be you. This EMS isn't totally crazy. And if they license a drug without even an observational study with a control group, presumably it's because they've seen a very large effect. So there's big problems with using historical controls. But if the historical controls 90% dead in 6 months, and with the new study 90% alive in 3 years, if I have cancer, I want the drug, right? Okay, because the effect is so great that even with, maybe it's not, maybe things aren't really that good, but we have no doubt under these circumstances that the treatment is better. You're using GRADE not to use it mechanically, right? Oh, it's only observational study, no internal controls, very low quality. But if you were putting aside your GRADE training and you looked at that and said, yes, it works, then that's really your certainty and you should be rating up. So the answer yes, you can consider it an observational study starting low with no internal controls. All else being equal, I would move it to very low with no internal controls. And subjective outcomes, you would be in very, very low, although we don't have that. But if there's a gigantic effect, you may be rating it way up again, even to high certainty. Maybe unlikely to high certainty. But if it was something like this, then you might say, well, we're not sure the effect is gigantic, but we're sure there's an effect that's appreciable. And so our certainty is high because it's such a large effect. Right?
So it's a kind of flexible.
Yes. So grade. So the message here is what one of my colleagues has said is, when you use grade, don't leave your brain at the door. Okay. So don't get. And another way to put it is, don't get rote or mechanical in the application. That's right. Okay. We provide guidance, but always step back and think, okay, overall, what is my confidence or certainty in this? And if your rote application of grade leads to something different than when you've looked at the whole picture, your intuition about it, there's probably something wrong. Probably not your intuition. But grade has guidance that clarify that. So usually the situation will be, if you feel confident, even though a rote application of grade would say maybe you shouldn't be, it's with a very large effect. That would be the typical situation in which that would be the case.
Next question.
Next question. We have some questions regarding assessing the overall certainty of evidence when making recommendations and guidelines. Well, we've talked a bit about that, especially making the leap from confidence in effect estimates to overall confidence with the body of evidence of certain recommendation. I've attached an example of a summary of findings table. As you can see below in the PICO question, some of the outcomes overlap a bit, like asthma control and symptoms. Also, we, the methods people, didn't quite get in the beginning of the process, always a problem, that asthma control could be measured in a variety of ways, like scales, number of the nights with awakening, school absenteeism, etc. So it can be hard in advance to know how your critical outcomes are measured in studies, and sometimes it's not possible to pool them into one meta-analysis. For example, any hospital admission and mean days in hospital, both of which are relevant in regard to the outcome hospitalization. Sometimes the problem is manageable, but by just taking the effect estimate that has the highest level of certainty, but other times you have low confidence in all the ways it is measured. If some of the downgrading is due to imprecision, and you feel moderately confident with this, would this be within the grade setup to announce that your overall confidence is moderate? Okay, well, there's a lot in that question. Let me read the last part again. If some of the downgrading is due to imprecision, but all the ways to measure it point in the same direction, and you feel moderately confident because of this, would it be within the grade setup to announce that your overall confidence is moderate? Okay, I'm not sure I'm fully clear. So if whoever asked the question wants to send us their Google address and come online and clarify, but for the moment, let's go to the summary of findings table they show. Okay, so if we look at this summary of findings table, we have hospital admissions at the end of treatment, okay? As it turns out, we have moderate confidence, but it looks like there's no effect, okay? So Hospital admissions, longest, that was end of treatment. Hospital admissions, longest follow-up is only low confidence. So it looks like there's an effect, but they say risk of bias and heterogeneity is a problem, and the imprecision doesn't look perfect either because the upper boundary of the confidence interval is only a 5% relative risk reduction. Children with any school absenteeism and children with any school absenteeism end of treatment, we have a 39% relative risk reduction, and this one is moderate confidence. Children with any school, that was end of treatment, longest follow-up. Here, we have lost our statistical significance, and we only have low confidence. But low confidence. Emergency department visits, end of treatment, very wide confidence interval, low. Emergency department visits, low follow-up. Now we have statistical significance, but it's low confidence. Asthma control symptoms, we have only moderate confidence. Okay, so so it looks like that overlaps no effect. Well, I guess the 0.1 is that it's 1.1 fewer nights to 0.1 fewer nights, I guess, because they just must be significant because they only rated down for risk of bias. Okay, so what's happening here is that we have some of the outcomes. Let's stay with that, please. Let's stay with the table. Okay. We have some of the outcomes where there is a benefit. So some outcomes benefit that's moderate, and some outcomes no apparent benefit. And these outcomes, if I understand it, I don't know if other people. Oh, yeah, thank you. I told you to stay with that, and then I started writing. My apologies. So some of the outcomes, moderate confidence. Some of the outcomes, no apparent benefit, and maybe low confidence. And and everything is either same direction or for some of those, no effect. And the question is this low, is the overall low or moderate? Okay? Let's go back to the table. Come around and look again, please. So, look at the table again. Would everybody agree with me? Some of the outcomes show benefit with moderate certainty. Yeah. Some of the outcomes show no apparent benefit with low certainty. Yeah. But either everything's going in the same direction or no effect. And the outcomes that show benefit seem to be equally important to the ones that show no benefit. Would you agree, looking at that table, that that's a accurate summary of what we see in the table?
Yeah.
Yes. Okay. So let's go back so that the audience can see us again. So with this situation, are we going to call this low confidence overall, or are we going to call it moderate? Low certainty or moderate certainty? What do you think, Carlos?
I would say moderate. So
Carlos says moderate. Sergio? Sergio's uncertain. Husney?
I think it's in between actually because both are equally important.
Okay, so Husney sits on the fence and says maybe it's low to moderate. Okay.
Yeah.
Carlos, why did you say you would rate overall moderate here?
It depends on the critical. I mean, if the outcome is critical or important, you usually have the.
Well, but we've decided these outcomes are equally important. That's why I stopped and said, do you agree with my assessment? Because I wanted to know that. So they're either all critical or none of them are critical. So they better all be critical. If they're equally important, then something's got to be critical, right? Or we wouldn't bother with this. So if they're equally important, they're all critical.
Yeah, and also because there is some benefit in some outcomes. And here, one of the questions is why are we including different measurements of outcomes? I mean, it's the same.
So the constructs are very, so what the questionnaires, methodologists were asking, they said, if they got in at the beginning, they may have said, let's just focus on these measures of asthma control. But they come in at the end, and the investigators basically said, we're going to look at all the measures of asthma control that the studies used. And the studies used a whole variety of measures of asthma control, and so that's what appears in the table. That's the picture of the evidence. Okay? So justify your rating of moderate in this situation.
Well, I don't remember the table, but based on the...
Go back to the table then. If you don't remember the table, probably the rest of the audience has forgotten the table too. And you can go back. And if Sergio and Husky have forgotten the table, you can come around and look if you like.
Yeah, it's quite large, so maybe it might be losing something, but yeah.
Okay,
Yeah,
so look at it. So how on the basis of that table can you justify moderate certainty?
Oh, yes. This is according to the.
Well, the first one you pointed at has no effect, right? The first one you pointed at has no effect.
Yeah.
So would you recommend moderate certainty? Would you recommend the strategy on the basis of that one? No, you wouldn't, would you? So we presume that the authors are thinking of recommending this treatment. What's the treatment? Structured patient education. The authors are thinking of recommending this, and what certainty are we going to attach to the evidence for that recommendation? And you, Carlos, has said moderate. So defend your.
Now I cannot, but yeah.
So now you think you have a problem.
I forgot the table.
You forgot the table. All right.
That was easy.
Okay. Well, except I tried to summarize it here. But anyway, so let's go back here. So here is the way and the blue one is my favorite, but it's disappeared. I don't know what I've done with it. So we'll try the black one. Okay, so some critical, moderate, and benefit. Enough benefit that you would recommend. Other critical, no benefit, or only low certainty. The question arises, if there was no benefit in these outcomes, but no harm, and there was benefit in these, would you recommend the treatment?
Yeah.
If the answer is yes, then you can say, I'm going to ignore, even though these started critical, in the end they weren't critical, because even if treatment has no effect on these, if this is true, I'm going to recommend treatment. That is the justification for using moderate. Now, the question is, can you say, but this requires that there's no harm in these ones.
Yeah.
And if you look back at the table, some of the, so let's look at the first one. Again, I'll show you some examples of these. Come around again.
Can I share that screen?
Yes, yes, of course. Whenever I say go to the table, please just share the screen. Okay. The hospital admissions end of treatment, the upper boundary of the confidence interval is 1.67, which is 119 more. That doesn't sound good. Okay. Here for school absenteeism, at the longest follow-up, the possibility is 84 days at school, missed more at school. Okay. If that were true, I don't think we'd be recommending the treatment. On the other hand, with everything going, with the point estimates, either nothing or going in the same direction, maybe it's very unlikely. So it's very unlikely that on long-term follow-up, there's less school absenteeism, but short-term, there's more school absenteeism. Doesn't make a lot of sense. The hospital admission end of treatment. Longest follow-up, we have less. Short-term follow-up, we have more hospital admissions. Okay, so you can go back to showing me again. So, two questions. Can we sometimes, when we have outcomes, a number of critical outcomes or equally important outcomes that we're going to say are critical, and some show benefit, but some are only low confidence, can we say moderate or high confidence to higher confidence? And the answer is yes, we can, as long as we're quite sure that these ones in which we have lower confidence aren't harmed. Okay? If these ones aren't harmed, then we can say, we don't care and the treatment, so these are no longer critical. These are the only critical ones. You just have to reassure yourselves that you've excluded harm for these ones. And this one might be a close call. Logic suggests that it's very unlikely there are these harm, although if you look at the confidence interval, just take it in a non-critical way, it shows it includes apparent harm. So this one is, I could say, this one, you could either go moderate or low. And that's the other thing with grade, right? Grade, we're not always going to agree because sometimes there are two reasonable courses of action, and this is one of them. You could say, okay, look, everything's going in the same direction. We don't have any point estimates that are serious harm. Very unlikely that these outcomes are harmful. We're going to call it moderate. Or you could say, well, the confidence interval around some of these include major harm. We really can't be sure there isn't harm in these, so we're going to have to call it low certainty. Okay? Mm-hmm. Questions? Okay, and the folks who asked the question aren't online. Okay, so again, for future, we hope to get people online because you who asked the questions, the people in the room may be happy with my explanation, but you may not be so happy and could ask further questions. But you're not here, so you'll have to accept that answer. Okay, next question.
Oh, okay. So maybe the last question because
we're running out of time.
Yeah.
We were wondering if there is specific guidance for how guideline developers can utilize evidence that does not come from a systematic review. All right. Utilize evidence that does not come from a systematic review. What are the possibilities?
For the individual studies or other
Yes, but I think our questioner is saying, how do I use these individual studies?
no, ideally you will have to do the systematic review.
Okay, so the first thing is, ideally, you do the systematic review. Okay? And the problem then, of course, is you don't have the resources to do your systematic review, or it's going to take you 2 years, and your community says, sorry, we can't wait 2 years for your recommendation. Okay? So yes, ideally you do your systematic review, and even if you can't do it quickly, you should do your systematic review so that when you update your guideline in 2 years, then you have the systematic review. But right now, I presume the questioner is stuck. They either don't have the resources, or there's some urgency to produce the guideline, and they can't do it at all because of lack of resources, or they can't do it in the time frame that is required. So they're stuck. Okay. So, yeah, so Carlos says, use the individual studies. Yes. How are you going to use the individual studies? Any suggestions?
Maybe very quickly they will go for a search, like immediate search, and
Well, they've got some studies. So you're now moving toward a quick and dirty systematic review. Okay. So you could do. So another possibility is quick and dirty. Okay, we're just going to use Medline. We're not going to try to be comprehensive. We'll just use what do you call the search strategy for the one Brian Haynes developed, but I'm blanking on the name within Medline. Clinical queries. We're just going to use clinical queries, and we're even going to use the narrow search for clinical queries and not even the broad search for clinical queries. Okay, so you do quick and dirty and you get your studies. Okay, so one way or another you've got studies. It's either because you knew about them before, or you do a quick and dirty search. Okay, right, so now you got your studies. Now what?
gather all the referring information, like the structure.
Well, so here is a question of there's no systematic review. What does the questioner mean? Okay, so yes, you summarize everything in evidence tables. Hang on. Hello? Okay. Could you just tell them that I'll finish up in a minute? I should have said that over the phone. Okay. So the question. So we're coming to the end. That's what that phone call was about. So I'll have to answer quickly. Okay. So you go as far as you can with your resources to make things systematic. Okay. Let me answer. Okay. No problem. So you do as far as you can to make things systematic. But then, so one of the things you can do is, if you have the resources, do a meta-analysis with whatever you have. Okay? So that would be, okay, so you recognize your sample may be biased, it may not be representative, but that would still be the best estimate. Okay? But say you don't have the resources for whatever reason even to do take the median of the estimates from the studies you have, and instead of a formal confidence interval, the range of results from the study which showed the biggest effect to the study which showed the smallest effect. Or leave out the studies that leave out the smallest and use the range from the studies that have reasonable sample size. Okay, so the bottom line in the answer, this is in this webinar thing for people asking about grade. So the question was, if you don't have a meta-analysis, what do you do? The answers are, you got the resources and the time, do it yourself. You don't have you have the resources, but not the time. Put out your guideline, but do the meta-analysis so that when you update in 2 years, you'll have the meta-analysis available. Okay, but what do you do in the individual situation? Perhaps a quick and dirty search if you have the resources for that. You get your studies, and if possible, even though you have an unrepresented sample, you do a meta-analysis. If for whatever reason that's not possible, you can do things like take the median estimate from the studies available and the range, or the range in some restricted sample of the studies which appear to be lower risk of bias or have the larger sample size. Okay, we have to stop now. Thanks for all those who have listened.
Well, we'll see you next month. We had a lot of questions this time, and we will be presenting the questions that we didn't answer the next month. Okay. Thank you very much, and thank you to the audience live. Goodbye.